Thank you everyone for joining us for the webinar, When Religion and Obsessive Compulsive Disorder Collide, and specifically focusing on scrupulosity. We here at the Partnership Center are working to encourage faith and community leaders to partner with mental health professionals to address mental illness. At that intersection, it's important to note that religious behavior can sometimes become intertwined with mental disorders. Scrupulosity is a form of obsessive compulsive disorder involving religious or moral obsessions where an individuals are overly concerned that something they thought or did might be a sin, and are overly concerned that it may be a violation of a religious or moral doctrine. In this webinar, we will learn more about this form of obsessive compulsive disorder and how it can be distinguished from normative religious practices and beliefs. We will also review treatments for scrupulosity and how mental health leaders can learn about and from faith leaders to better inform their treatment protocols. Finally, we will apply some lessons learned from the research and clinical literature on scrupulosity and faith to other mental health disorders. Joining us for this presentation today is Dr. David Rosmarin, who's become a great friend of the Partnership Center. Dr. Rosmarin is the director of the Spirituality and Mental Health Program at the McLean Hospital and is assistant professor in the Department of Psychiatry at Harvard Medical School. He supervises the provision of spiritually integrated services in clinical units throughout McLean's divisional structure and collaborates with laboratories to study the clinical relevance of spirituality to anxiety, mood, psychotic, substance use, and other mental disorders. He is also a prolific researcher, having authored 70 peer-reviewed scientific publications and editorials, book chapters, and over 100 abstracts. So without further ado, Dr. Rosmarin, we're excited to jump into this important content that you have to share with us today, so take it away.
Thank you, Ben. I really appreciate that gracious introduction. And indeed, I'm definitely a friend of the Partnership Center. I think the work that you're doing and your colleagues over there is just wonderful. When it comes to faith and spirituality and religion, these are often important resources that get ignored and important aspects of mental health that are just not spoken about in the academic world and even in the clinical world. So the fact that you're leading the pack and keeping us all on task and reminding us of the importance of that, I think at the national level is just wonderful, and I'm glad to be part of it. And I'm happy to speak about something specific today on religion and OCD, and I guess let's dive right into it. If I can get my slides to go. There we go. Okay, so I started out in graduate school, and people used to ask me, you're a religious person, right, Rosmarin? And I said, yeah. And I said, well, how are you going into clinical psychology? Don't you know that religion can make you crazy? So I usually shrugged off the question and just laughed. But in truth, as an Orthodox Jewish individual, I found it to be a very strange question. Firstly, in the course of my studies, I had met and learned from some of the world's most preeminent mental health scientists and clinicians, but I can comfortably say that the most psychologically insightful people I've ever met are clergy, who are actually ordained clergy people from various faiths. And the more I learn about clinical science, the more I see an uncanny resemblance, in fact, to many teachings from religious traditions around the world. Today, I don't get that question anymore, and it's not just because I'm a professor. It's because people are more open to religion and spirituality due to, well, mass interest in mindfulness meditation and other aspects, and also because of the good work that the Partnership Center is doing. And as a result, I hardly get asked those questions, thank God, anymore. Well, actually, I'll just go beyond that. I was even recruited to my current position in Boston because of my research interests in spirituality. However, there are a couple of areas in which it's widely perceived anyway that religion can cause people to have distress. And one of those areas is the subject that we're speaking about today, which is religious OCD or scrupulosity. So this is a challenging one to address because, especially to a diverse group that we have, but I'm going to do my best to go through how can one tell the difference between religion and OCD. Does religion, in fact, make people develop OCD? It's an important question we have to ask. And also, how do we treat religious OCD? And that's my goal. So let's start with the first question. How can one tell the difference between religion and OCD, observance and obsessiveness? Have you ever seen people pray the rosary? So I'm not a Catholic, but my understanding is that you have a crucifix, and then there's the sign of a cross, which is made, and then there's an Apostles' Creed, which is stated, which is this established statement of Trinitarian belief. And then there's another large bead, and on that one, there's an Our Father. That's a 56-word prayer for sustenance and forgiveness. And then on each of the following little beads, there's Hail Marys, which are stated. Then there's a chain, and on the chain of the rosary, which is prior to the next small bead, there's another prayer called Glory Be. It's a 26-word prayer. And the rest of the ritual, it depends on which day of the week it is. On Mondays and Saturdays, it's 5 sections from the verses of Luke. On Tuesdays and Fridays, it's verses from Matthew. Wednesdays and Sundays, it's John, Luke, and Acts. And there might be different versions of it, but either way, we're talking about a fairly scripted, ritualistic act. And there are different parts to praying the rosary, but you basically get the point, is that we're talking about a very highly standardized, systematic ritual, no matter how you dice it. That's what it looks like. And similarly codified rituals can be found in Buddhism, such as a prayer wheel, which is very intricate, thousands, even millions in some of them, mantras, which are wrapped very carefully around a cylinder made of wood or metal, and they're written in the language of Nepal, Newari, and the wheel is spun clockwise, not counterclockwise, either with the hands or with the forehead, while a meditation is done with very specific intentions which correspond to the prayer wheel. There are also days of the month that are more auspicious or less auspicious in which people engage in these practices. In the Jewish world, we also find very highly regulated rituals. In the morning prayer, before the morning prayers each day, traditional Jews or Orthodox Jews, as depicted in the picture, will wash their hands in the following way, and this is actually written out in the Code of Jewish Law explicitly, to pick up a 2-handled cup with one's right hand, to fill it, transfer the cup to the left hand, pouring at least 3.8 ounces of water over the right hand, and doing that multiple times, either 3 or 4 times, depending on custom, and then drying one's hands well before praying. These are just a couple of examples from different faith traditions where we have ritualized practice, specific ways to pray. We have specific ways to eat, walk, speak, greeting others, governing over different aspects of life. And let me ask you, in these few examples that I've shared with you and the many, many others, is this religion or is this OCD? Many people think that it's OCD. It's obsessive, seems to be obsessive, and people are very punctilious about what they do. So let's just define OCD, and then we can see, is it religion or is it OCD? OCD is a heterogeneous disorder. That means there are lots of different ways that people can develop OCD, can manifest, I should say, OCD. There are lots of different subtypes. One of them involves counting. Counting involves basically becoming obsessed with certain numbers. And those numbers have significance, and the person feels compelled to count up, either up to or down from those numbers, usually to avoid certain negative consequences. Interestingly, people with OCD will usually know in their minds that the counting doesn't really avoid negative consequences, but they feel that they can't abstain from doing so. And the obsession that they have is, I must count, and even though they know that it doesn't make sense, it's not really going to help, they can't resist the urge to do so. It's very strong. So let me ask you, how is counting different from the rosary? We have after a certain number of beads, before a certain number of beads. It's an important question, and we're going to get to it. In another type of OCD, people have an urge that they have to feel just right. This is a little bit harder to pinpoint. For example, once I had a patient who needed to feel just right when walking through a doorway. Otherwise, he would go back out through the doorway and then in through the doorway as many times as it took to feel just right before he would walk in. He would also often touch the doorposts and the lintels when going into a room in order to help him feel just right. So how is this different from that prayer wheel where somebody has a certain thought that they have to have on a certain day with a certain rotation clockwise, not counterclockwise? What's the actual fundamental difference? And furthermore, in another subtype of OCD, patients are obsessed with cleanliness and being free of dirt, germs, and the like. And in many cases, patients will wash their hands in a very specific way. I had a patient who was concerned that they might have the AIDS virus, and he knew he wasn't HIV positive or infected with AIDS. He'd been tested. But in order to cope with the thoughts, he would practice very careful hand hygiene, allowing the cup to, an overflowing cup with two hands. He would cup his hands together and allow the water to overflow for about a minute, then increasing the amounts of water through the fingers, pumping exactly 2 pumps of dial liquid soap, no other brands, into his left palm, massaging it through his hands, through the index finger, then the middle finger on the right hand, and then on the left hand, lathering each finger separately, thumb, index, middle, ring, pinky, and then the back, front of the hand first, then the back, and doing this every single time. So is this really fundamentally different from ritual hand washing, which we spoke about before? I'm putting the question very poignantly. I'm trying to, how can we truly tell the difference between religion and OCD? To answer this question, we need to define our terms. We need a dictionary. What's religion and what's OCD? And as you will see, they are completely different, completely different. My advisor, Dr. Kenneth Pargament, at Bowling Green State University, my graduate school advisor, he's published enough psychological research on religion that he actually has his own definition, which became very common in the clinical science world. According to Dr. Pargament, religion involves institutionalized or culture-bound ways of defining and relating to the sacred, defining and relating to something which is set apart from this world. So if any group has a systemized description of God or something like that, or a systemized way of connecting to spirituality, that is religion. By contrast, in the Diagnostic and Statistical Manual of Mental Disorders, OCD has 2 components. First, there are obsessions. Obsessions are recurrent, unwanted thoughts that somebody does not want, or impulses or images, so ideas that are going on here in one's mind, that they cause a person marked anxiety or distress. They're very upset by those thoughts, and the person attempts to ignore them, or to suppress them, or to neutralize them. The nature of an obsession is an unwanted, upsetting thought or image or impulse that a person doesn't like, and we are trying to get rid of it. We want to ignore it, or suppress it, or get it out of our minds. A compulsion is a repetitive behavior or a mental act, it could be done in the mind, that a person feels driven to do in order to get rid of their obsessions. And the goal of that is to reduce the anxiety, to reduce the distress, and the nature of those compulsions is that they are definitely excessive. They are clearly not normative what other people are doing. To be clear, the hallmark of OCD is distressing obsessions. It's all about those obsessions. It's somewhat akin to a thought phobia. One of my colleagues, Dr. Jed Seeve, he taught me that years ago, and I think it's spot on. When people have a phobia of a dog, they're afraid of the dog. What if somebody has a phobia of a thought that's in their mind? That's OCD. When we have a phobic reaction to a thought, we're trying to ignore it, and then the person engages in these rituals in order to try to get rid of it. Okay, it's important that obsessions and compulsions, according to the DSM, are not due to a substance use, specifically due to a substance, physiological effects of a substance, a general medical condition, and they are also not specifically cultural practice. That last piece is important. If these are cultural and they're normative and there's a group of people who are doing them, then they're not OCD by definition. Based on those 2 definitions, religion and OCD, it is very clear that normative religious practice, even if it is highly ritualized, even if it is highly punctilious and specific, is categorically and unequivocally not obsessive compulsive disorder. First, we have the cultural practice exclusion. The DSM is very clear that if something is culturally normative, it is not OCD. And all of the aspects that I spoke about before, whether it's the rosary or whether it's the prayer wheel or whether it's ritual hand washing or any other aspect of eating, drinking, which is governed by a religious group, by the practices of a religious group, that is a cultural norm. That is not OCD. But more fundamentally, there's a conceptual piece here. Consider the religious practice examples: the rosary, prayer wheel, hand washing. Are those being driven by unwanted thoughts? No, that's not what religion is about. I mean, it could be that they are, and we'll talk about when religion co-opts OCD, but that's not what's driving it. The thoughts that are driving the behavior are not obsessions. They pertain to trying to connect with something greater. The reason why people are engaged in those practices, the prayer wheel, is to try to connect with God or something which is perceived to be greater. Same with the rosary, same with the prayer, same with the ritual hand washing, same with other prayers. The goal isn't to get rid of obsessive thoughts. That's not the purpose of it. And with regards to compulsion, some of the behaviors might be repetitive, right? People are doing the same thing over and over again, but it's missing the hallmark of OCD, which is obsessions. And secondly, those are just systematic, institutionalized ways of relating to the sacred. The behaviors have nothing to do with anxiety or distress. And even if there is a fear or anxiety, that's not the driving force. The reason why people are engaging in it is to try to connect to something greater. That's what makes it religion. That's Dr. Pargament's definition. Where's the thought phobia when it comes to normative religious practice? Where's the thought that the person's allergic to? It doesn't exist. Where's the excessive reaction to the recurrent unwanted thoughts? There's no obsession and there's no compulsion. Therefore, religion is not OCD, period. It's not. By contrast, when we look at obsessions and compulsions in all the examples that we were speaking about, we see very clear, we see that both of them are clear, including the distress. The counting OCD, the person has an obsession, a recurrent unwanted thought that I need to count to the number 6. And those thoughts cause me a lot of distress. If I don't count to 6, oh my God. And the person's engaging in the compulsion in order to feel less distressed. I count to 6, I feel better. When we do the counting, then they get a little bit of temporary relief. Now, by the way, counting makes it worse in the long run, as I think we'll get to. For the folks with the just right OCD, they have an obsession that they need to feel a certain way at a certain time, and that causes them distress. In other words, they're obsessed about something, and the ritualistic, repetitive engaging and going in and out of the door until they feel just right is a compulsion which provides a drop of relief in the moment in order to relieve the distress associated with the obsessions. The same thing with the hand washing, not the ritual religious hand washing, but the patient I mentioned before who had the AIDS, who didn't have AIDS, thought he had AIDS, who was obsessed about it. He was obsessively afraid of germs and dirt, and washing gave him that sense of relief. His obsessions led to anxiety, which led to those compulsions of washing, which led to relief, which actually increased the obsessions over time. So let me answer our first question. How can one tell the difference between religion and OCD? Religion involves connecting to the sacred, and OCD involves obsessions and compulsions. It is that simple. Now let's move on to question number 2. Religion and OCD might be different, but maybe religion is close enough to OCD that it makes people develop the disorder. After all, you do see that punctilious, scrupulous, careful adherence to rules in many religious contexts. Maybe that generalizes and people are more likely to become compulsive and obsessive when they have that. In other words, maybe focusing on all the nitty-gritty details and ritualistic behavior is a risk factor for becoming more obsessive and more compulsive, or maybe anxious in general. Well, to answer this question, we need to understand something called epistemology. Epistemology is the philosophy of knowledge. It's a term I picked up doing a minor in philosophy in my undergraduate studies. And the philosophy of knowledge, or epistemology, determines which sort of information you can and cannot use in a given situation. People make a critical error in answering this question and other critical questions by drawing on anecdotes. They'll say, oh, I know somebody, they were religious and they became obsessive, and therefore religion causes obsessions. No, the answer to the question needs to be drawn from systematic research, and that is the epistemology here. The philosophy of knowledge would dictate that taking a systematic, empirical approach is a better path. Just to make it very clear, Sigmund Freud, he concluded based on a couple of cases that there were similarities between religion and OCD. And he further thought that religion was a risk factor for obsession, which he summed up very clearly in this terse phrase, which is on your screen. Now, he might have been wrong, but he wasn't crazy. It is possible for people to have OCD that co-opts their religious practice. Recently, I saw a 62-year-old man. He repeated his prayers for between 1 and 4 hours every day because he wasn't sure he said them properly. When he finally did say them correctly, he was consumed with doubt. Maybe I did, maybe I didn't, maybe they'll be answered, maybe they won't be answered, my prayers. And he spent hours upon hours mentally reviewing what he had said during those prayer services. He was also very careful, scrupulous, to only have pure thoughts, especially during prayer, in order to guard against spiritual impulses, spiritual impurities. Here's another case. A few years back, 47-year-old married woman who repeatedly said verses and prayers every time she had a bad thought in her mind about a friend or a relative. She might think that her friend was getting sick or might get into an accident. So she would stop the thought and say verses and prayers in order to prevent the bad things from happening. And she was plagued by these thoughts that she didn't repent correctly and repeatedly confessed her sins to God and to other people. So, by the way, are these OCD or religion? Clearly they're OCD because the beliefs and the behaviors are not culturally normative. It's not common for people to pray in the 62-year-old man's culture between up to 4 hours a day. That's not usually done. And with the woman, to go over her level of distress was obviously not the same as people in her culture. And furthermore, they weren't trying to connect to God. Their religion was being hijacked by obsessions and compulsions. What they were really doing was being consumed by fear about their thoughts, not even fear of God, specifically fear of their thoughts, and that's what was driving them in order to have their compulsions. So, maybe though religion causes people to have OCD. I'll tell you about another case. A single man in his mid-20s, plagued by thoughts that he has committed an unforgivable sin. He believes in God, but he sometimes has thoughts that maybe his beliefs aren't true, and he thought that was unforgivable. During his prayer and while studying religious texts, he had bad words that come into his head. Sometimes he feels like he's had those thoughts and said those words about Jesus or about the Holy Spirit, even though he definitely has not. After several sessions, he confided in me that sometimes he imagines doing actual sexual acts with other people while praying, and they come into his head, and he's extremely distressed by these thoughts, understandably. And these thoughts eat him up inside. They won't let him leave his head. He is, sometimes he doesn't even go to church, and then he feels more guilty about the fact that he doesn't go. So, is this religion or OCD? Very clearly OCD, because it's normative to be distressed. Yes, of course, anybody having sexual or blasphemous or expletive thoughts and having religious sensibilities would be distressed by that. But the degree of thought control that the person wants to control their thoughts, it's not normative relative to his religious culture. Because the reality is everybody has bad thoughts from time to time, everybody. And while most people are able to dismiss them and move on with their life, this person is getting stuck on them, on those small moments. And his obsessions, they look religious, but they're not. They're actually OCD. So getting back to the question, does religion develop help people or make people develop OCD. So in certain cases, definitely OCD has religious themes. Definitely we have scrupulosity, it happens. But from an epistemological standpoint though, the only way to answer the question is with quantitative, systematic research, by crunching the numbers on whether religion is really a risk factor for OCD in the general public. And fortunately, there have been over 30 published studies on the subject. And the studies have been conducted in the United States, in Canada, in Turkey, in Egypt, India, Italy, Israel, and many other countries. And the research has been done with Christians, with Jewish populations, with Muslims, and even with atheists, interestingly. There's lots of different populations of study which have been in patients, people who have OCD, also in the community, in religious communities of people who do and don't have OCD. I'm not going to bother you with an exhaustive review of the literature, but fortunately I don't need to because it's very clear. There is no empirical evidence to my read that religion causes people to have actual OCD. I am not aware of any evidence to suggest that religion causes OCD. And if someone tells you that religion makes people develop OCD, please ask them for the research and please send it to me by email, because I would be very, very interested to read that paper. It has definitely escaped my attention until now. Just to round this out, the vast majority of individuals across the United States have religious and spiritual beliefs in some ways. By all counts, no matter how you dice it, more than 50% of this country is fairly to very religious. Yet, OCD impacts just 2.3% of US adults, and that's over the entire lifespan, and 1.2% at any given time, about 1 in 100 people. And individuals with OCD, they're not more nor less likely to be religious. If you take somebody who's OCD, compare people who do have OCD and people who don't, you do not find there to be religious differences between those two groups. If anything, we find that religion and spirituality is actually associated with lower incidence of things like depression, suicidality, substance abuse, and misuse. And also when people have positive beliefs about God, that tends to be associated with less anxiety in general. One important exception, however, is this. When people have a religious background and they develop OCD, they tend to have religious symptoms. Their symptoms tend to take on religious themes, okay? And individuals who have religious OCD tend to fare a little bit worse. I think it's not because of the nature of the symptoms. I think it's because the treatment of religious OCD, a lot of clinicians don't really fully understand it, and a lot of individuals are confused by it. These basic questions that we're talking about today are confused. They're confused about it. Is it really my religion? Did it set me up? Should I be religious? Should I not? And all those questions make a very specific, localized mental health problem into a global spiritual struggle. I'm going to explain this a little bit more later, but for now, it's very clear, at least to me, that religion does not seem to cause OCD. But that does leave us with another question. How can we understand religious OCD? What is this religious phenomenon of an OCD? And I mentioned it before, but I'll say it again. It's very simple to me. When religious individuals have OCD, their symptoms tend to take on a religious flavor. If non-religious individuals develop OCD, their symptoms tend to take on a non-religious flavor. When religious folks have a contamination OCD, they're concerned about contamination, they're less likely to be concerned about the AIDS virus, and they're more likely to be concerned about spiritual impurities. And when a religious individual has concerns about symmetry and exactness and things being exactly perfect, then the obsessions tend to focus on, did I perform my rituals correctly? As opposed to a secular individual who might be ordering their shirts in their closet alphabetically or in another way, orange before purple because O is before P. And when individuals are concerned about bad thoughts, it's usually not just a generic vision of people having accidents or people having bad things happen to them, which happens in the secular world. It's usually blasphemous thoughts, adulterous thoughts, ideas that transgress their cherished religious values. In fact, this is basically the case for OCD in general, that OCD usually gravitates towards whatever is most important in a person's life. For many people, that's their faith. So it's no surprise that when religious individuals have OCD, it's going to attack that which is most precious and most important to them. Let's move on to the final question, and then I guess we'll have time for discussion. What do we do for our patients who have religious OCD? How do we treat religious OCD? Well, advances in behavioral health over the past 20 years have developed amazingly effective psychosocial, non-pharmacological therapy techniques or interventions for a number of conditions that have a very clear biological basis. For example, enuresis, or the inability to control when one's urinating, insomnia, hypertension, tic disorders. All of these have a clear biological basis, and OCD is no different. There definitely are neurological bases for OCD. However, the treatment of, in fact, all of those conditions, enuresis, insomnia, hypertension, tic disorders, and OCD, the treatment of choice for all of those, at least the gold standard treatment, is actually going to be a non-biological treatment called behavior therapy. In the case of OCD, behavior therapy is very well researched and widely practiced. And we had it on our previous slide, the cognitive behavioral model. We saw a version of it before anyway. In a nutshell, people have a situation or a trigger which leads them to having certain thoughts. When they have those thoughts, they feel emotions, distress, they're upset about it. That will lead them to engage in a certain behavior, compulsions. They have different physical reactions. They feel a little bit less intense. And then that, ironically, makes their thoughts worse over time. Behavior therapy is remarkably effective for OCD. For people who complete behavior therapy, otherwise known as exposure therapy, 80 to 90% of individuals who successfully complete a course of behavior therapy for OCD can have reductions in symptoms over a course of just 8 to 12 weeks. It's not always the case. There are people who don't respond, for sure, but in 80 to 90% of cases, between 8 and 9 out of 10, there is one major drawback, which is the dropout rate. It's not easy to do exposure therapy. I'm going to describe the treatment soon, but basically 20 to 30% of individuals who start treatment end up not completing it because it is very challenging for them to do. Nevertheless, exposure therapy and behavior therapy are first-line interventions for OCD, and actually the data seems to suggest that they're even more effective on the whole than SSRIs like fluvoxamine and Luvox, and also tricyclic antidepressants such as clomipramine and enafrenil on the whole. By the way, that's not to say that people can't do both. Often people do both and they do perfectly fine. Let's just talk about what exposure therapy looks like. We described it before. The symptoms of OCD have these obsessions, a person's thoughts, and then unwanted or upsetting thoughts, and then there's the compulsions, which are behaviors in order to decrease the unwanted and upsetting thoughts. In exposure therapy, patients are encouraged to expose themselves to their feared thoughts. In other words, to bring on those bad thoughts, to let them just happen. In fact, to engage in behaviors that will cause them to have those thoughts. And then they prevent themselves from engaging in the response. They do not engage in any compulsions. If someone has a fear of germs and contamination, we would probably encourage them to touch things in public, like a staircase handrail, or around a subway car, or even around a toilet, and not wash their hands until the distress goes away. A person who compulsively checks the stove or the door in order to make sure that it's locked or that it's off, they would be encouraged to lock the door, turn off the stove once and simply leave. They might also be encouraged to leave the stove on and to leave the door unlocked and to leave without checking at all. Towards the end of treatment, we actually increase the ante, right? I've left an iron on for a few hours with my patients, eaten food off the floor, I hate to say, even stuck my hands inside of a toilet bowl, with my patients, not an easy treatment even for the therapist, but I got to do it too. Initially, patients' anxiety and their distress, it goes way up. It skyrockets as they do these activities. And over a course of time, 30 to 60 minutes, distress does come down. And over time, it gets easier. The next time, it's easier. And then the next time, it's easier. And then we can conquer higher orders of business. One important point, though, with exposure therapy is that we push the limits, but we never violate the laws of nature. I would never encourage my patients to do something that is objectively dangerous or unsafe. For example, I will ask patients who are concerned about contamination to touch the outside of a biohazard box which has needles inside. But I would obviously never ask them to put their hands inside the box. Patients can be encouraged to put on an electric stove and to leave the house, but not if they have loose curtains hanging. And similarly, when it comes to religion, we employ the exact same approach. For the 62-year-old male I mentioned before, who was repeating his prayers for hours each day, he says to simply say his prayers, not being repetitive, and if he repeats, the rule is that he must skip the entire section and cannot return to that section until the next day, period. So if he starts to repeat, he stops and he moves on. He needs to tell himself between prayer sections, maybe I didn't pray correctly. He has to specifically tell himself that. And intentionally, and sometimes we have him have these impure thoughts while praying and to pray in a contaminated manner. And that's not easy for him. For the 47-year-old married woman with those bad thoughts, she's encouraged to have those thoughts about her family members, God forbid, getting sick, having accidents, and then letting go of them without engaging in her recitation of Psalms or other things like that. With regards to her repentance or over-repentance, she can repent once and then never again for anything, not to God, not to anyone else. That's the rule with her. And for the single male in his mid-20s that I mentioned, he's encouraged to think thoughts that would bring upon unforgivable sins to him and just to let them go, just to let it go. He was encouraged to think bad words and inappropriate thoughts during prayer, which was extremely hard for him, understandably, and to go to church and not avoid any religious activities. At first, he was avoiding church, right? So we had him not avoid any religious activity or any images because of his OCD. Now, just like we don't violate any natural law in exposure, right, the inside of the biohazard box, we don't also violate any real religious law. But we do push right up to the limit of religious and natural law. The whole point of exposure therapy is to violate what we call OCD law. We want a person violating their own internal construction of what they need to do based on their obsessions without violating the natural law or the religious law. For this reason, exposure therapy is very difficult for practitioners. Many clinicians have some experience with it, but even it does take quite a bit of experience and training even to handle obsessions and compulsions of a non-religious nature. When it comes to religious OCD, it can be very complicated to determine where does the OCD end and where does the religion begin, or where does the religion end and where does the OCD begin. For this reason, clinicians and patients actually have to have a fair amount of working knowledge of patient's normative religion, like what is normative and healthy, so to speak, for a patient in order to come up with appropriate exposure activities which are going to push beyond that to only what's OCD. For these reasons, I'm a big fan about collaborating with clergy. We have different clergy folks from different religions who I will call depending on what religious background the patient is from. In many cases, it's very helpful to have clergy and faith leaders and clinicians working together when it comes to scrupulosity and religious OCD. And that's one of the reasons why OCD tends to respond worse to treatment. Individuals with religious OCD compared to, patients who have OCD and they have religious OCD versus patients who have OCD and have non-religious OCD, the former will tend to be worse. People with religious OCD tend to fare worse, and that's one of the reasons why. People don't know where clinicians often don't know where religion ends and OCD begins. But another reason why is as follows. Exposure therapy is very challenging. It's extremely challenging. And for religious individuals, it's not only a test of will, it's also a test of faith. There's a famous Jewish parable, actually, which I'll share with you, of a man, and he falls off the side of a cliff. And he manages to catch onto a branch on his way down. And he holds onto that branch. And he says, God, I will do anything if you get me out of here. I'm 100 feet from the ground. I need your help. Please, please, please help me. And he hears a voice. And the voice says, do you want to get out? And he says, yes, please, please get me out. He says, will you really willing to do anything? And the man says, I will do anything. I will do anything that I possibly can. And the voice says, let go of the branch. Let go of the branch, and I'll catch you. That's what OCD treatment is like. And a lot of people will say, no, I'm not letting go of the branch. I prefer to suffer in this world, so I don't go down to hell. And that's a hard thought to refute. It's very hard to refute that thought. But this is the very reason why completing exposure therapy for religious OCD, it's not only an emotional experience, it's also a religious experience. Because many people come to OCD treatment and they feel very stuck, not only emotionally, but spiritually, because they're being chained by the constraints of their obsessions. Their obsessions won't let them let go. And they're stuck religiously and spiritually as a result. And exposure therapy encourages them to boldly stand up to their fears and to trust that God will take care of them. That's what it comes to. The whole process involves giving up control, letting go of the branch. In many ways, it's a test of faith, not only in one's therapist, but also in one's self, that one can do it, and ultimately in a benevolent being, God, that things are going to be better when we do what we're supposed to do, even though it seems impossible. That ultimately is what exposure therapy is about. It's truly about letting go and letting God take care. So in many ways, as I mentioned at the beginning, what clinical science is telling us and teaching us about a healthy way to live is very similar, eerily similar, to many of the things that religion has to teach us as well. Thank you very much.
Dr. Rosmarin, thanks so much for that presentation. So engaging. I know I echo a lot of people sharing that they appreciate all the different examples that you provided that are really helpful for putting this into context and helping us think through some of those considerations. So first question's from me, and it's one we talked about before, but what are some of the connections that you would make and express to other clinicians, especially, of which I think we have a lot of people who are out in the field doing work? What can we take from this understanding and description of scrupulosity and the ways in which we address it through treatments in thinking about treating other forms of mental illness? What are some of the considerations and learning that we can take from this process and apply in other contexts as well when we think about other disorders?
Yeah, I think that's a great question. We see here that, religion and spirituality and mental health are related in three ways. In many cases, it's a positive. It can really help people. In some cases, it can create struggles when people feel that God is out to get them, or they feel very disconnected from people in their faith community. And in the third case, which is what we spoke about like today, where you have a person's symptoms are manifesting in a religious framework. Those three ways, positive, negative, and then the coloring of symptoms, those can occur in other areas of psychopathology as well, whether it's depression or in eating disorders, or whether it's in substance abuse, at least the positives and negative aspects there. There are many cases where that can happen. So what I would encourage the clinicians is to assess for aspects of spirituality, which are usually ignored. Most clinicians don't get training in how to assess for and address aspects of patient spirituality, and to treat this domain like you would pretty much anything else. not to be afraid to discuss it with patients and to raise it with them.
Thanks, Dr. Rosmarin. That kind of connects us to a second point that I think is important. And I was reminded of a presentation by Dr. Miller where she talked about having a client present who some people were, she was in the institution because they didn't believe that the practice that she was engaging in was a healthy practice. And Dr. Miller, I think if I remember correctly, or was someone who presentation that I think both of you and I were at, talked about how they went out and found the faith community that they were participating in, learned that that was a normal practice for that faith community, and brought that back to the practice and said, you know, no, this person is exhibiting a behavior that is a cultural practice within the community that they participate in. So can you talk a little bit about how that kind of cultural competency and understanding a client's background and community is a key part of making sure that we an assessment for a client and determining when OCD and or religious behavior is present?
Yeah, that can definitely occur, Ben, and yeah, I do remember that story. When it comes to religion and OCD, I tried to make it clear before that a clinician really needs to demarcate very clearly where does the religion end, where does the OCD begin, and not to either be too conservative about it and also not to be too liberal. The truth is, in dealing with my OCD colleagues, if anything, they tend to be too conservative about it and actually not encroach enough upon the symptoms. They'll actually be, in some ways, I mean, at least the individuals I've spoken with about it, and a fair number of them at that, tend to be, oh, that must be religion, so I don't want to go there. And upon further identification, it's like, no, that's actually OCD. The line is further out. But with that said, I think you're right that some clinicians might go too far in. So really having a nuanced understanding of the patient's religious culture is it's really necessary when it comes to religious OCD, scrupulosity, and other areas where symptoms are co-opting, religion is co-opting symptoms as well. Excellent.
There was one question regarding how to factor in the helpfulness as a factor in determining the difference. Like, so the helpfulness of the practice to the individual and whether or not, like, you know, so somebody prays and they pray a lot, but it makes them feel better. You know, and how does the helpfulness of the behavior relate to our understanding of it? Because certainly there's a coping mechanism, right? They're adjusting and doing these behaviors in such a way, it does bring a sense of relief. That's kind of that strategy. But then how does that get addressed as far as any number of different ways of looking at this, whether or not it's assessment or diagnosis or treatment?
Yeah, it's a fantastic question. If a patient's engaging in something that's helpful, at least to them, it's hard to say that that's a psychopathology. At the same time, sometimes we do see patients with OCD who have low levels of insight, and they actually don't recognize that certain aspects of what they're doing are not really functional at all. I've seen patients who are praying or engaging in religious rituals for 6, 7, 8, 10, 12 hours per day. And if you ask them, they'll say, oh, I like it. But really what's going on is it's being driven entirely by fear. So that's why I think a better model is to focus on the cultural values and is it normative? Is it what other people are doing within the culture? But you're right, at lower levels of distress and lower levels of pathology, I think it does make sense to also just ask the person flat out, is this working for you or is this too much? And would this be something you'd like to change?
Hopeful, thank you so much. What are some things to think about when some of this behavior overlaps with other conditions? One specific condition mentioned was dementia. And thinking about co-occurring disorders in addition, like when some other disorders are looped into some of these as well. And so I think this relates to general practice and making sure you're addressing the most severe symptoms first. But someone did ask a question as it relates to their work connecting to other symptoms and challenges, other disorders that may be present.
Yeah, it's a great question too. The most common comorbidities when it comes to OCD is going to be depression, where people are also sad, they're anhedonic, they're not enjoying life as much. And it makes sense when people are having OCD that, you know, life is more burdensome and difficult. When it comes to that comorbidity, it makes a lot of sense, I think, to integrate spirituality for patients, because often that can provide a lift. It can provide a sense of meaning, a sense of hope, a sense of purpose. a sense that they're connected to something greater. There are other anxiety disorders also that are commonly occurring with it, and for those as well. When it comes to dementia, that's a lot. That's something I would actually have to think about, because dementia is also a cognitive disorder in many ways, and how would that interplay with OCD? I haven't really done much work on patients with co-occurring dementia and OCD, so I want to give that a little bit more thought before responding. But the point is definitely taken that comorbidities occur, and we have to think about the whole person, not just the disorder in front of us.
And certainly I would say David has his email address here on the screen. He is really helpful and responsive on many different questions that come in. I know he wants to be available to everybody who's joined us today, so feel free to reach out if you have a question related to a very specific area of comorbidity that may be present. David, these questions that turn us a little bit more towards faith leaders, I guess.
Great.
What about when religious behavior is one that is encouraged by the tradition or a religious leader themselves? And what is the role of the clinician in working with that client to better understand some of that overlap then? Or even if you have any examples of challenging environments. So not only we have to acknowledge that sometimes a relationship with a faith leader can be helpful, and there are some times when a relationship with a faith leader can be a challenge to the treatment protocol. And so some consideration and conversation about that would be helpful.
Yeah, those are good points. I would hope that any faith leader is encouraging individuals to adhere to behaviors which are normative and really valued by a larger group, not just sort of a specific group or that specific church or mosque or whatever it is, or synagogue. So that's first of all, and I would definitely be a little bit weary dealing with certain religious leaders who are more highly specific in their approach as opposed to more broad-based in terms of their culture. I think ultimately when it comes to faith leaders is psychological mindedness. Is the faith leader tapped into the fact that this individual is in distress, and that is ultimately a barrier to their spiritual growth. If the faith leader has in mind simply to have that individual or other constituents following party lines behaviorally and being adherents, as opposed to having a healthy relationship with themselves and with God, then I think you're right. It could be actually, a potential drawback. I will say though that those experiences I've had as a clinician in collaborating with clergy are fairly rare. I've had, by and large, very positive experiences across different faith traditions. Maybe I just get lucky, but it's a fair amount of data for me working with people. So I'm encouraged by it, but notwithstanding that, that's anecdotal and that's just my experience, and there might very well be harder people to work with. I'm sure there are.
Yeah, and I think it's just a recognition that we need to acknowledge that there may be challenges present, and so those need to be worked through and addressed and considered with each individual case. So it's certainly important to think through those. As a part of this engagement that you've had with faith leaders around some of these disorders, are faith leaders then kind of more attuned to some of these challenges and considerations? Can then, like a faith leader, you'd be working with a client, they say, wow, I had never thought about that. And then that may lead to that faith leader being more aware of someone else who may be in distress, who then has a better awareness of mental health disorders that leads to more engagement with you as a clinician. Does that question make sense? Kind of when it's not just the initial engagement and learning, but also how that learning may translate into more referrals, more understanding from the faith leader as it relates to other forms of mental health diagnosis, sometimes which may include OCD.
I think that's a very good description of what often happens, which is that we're really building relationships. I'm happen to be a religious individual, but I'm a clinician and a researcher, and that's my side of the coin. And in engaging with faith leaders, I think, firstly, I learn a lot. And I also hope that they learn not only to help the individuals we're consulting about, but also other individuals in their communities. But I also want to underscore how much I have to learn from faith leaders and how much I have learned from faith leaders. I think that the information definitely goes both ways.
That's a great point. One last question. We did not get to all the questions. You guys had such wonderful questions, and I appreciate everybody jumping in, but we hope we got to a lot of what the questions is you had. Also, I so appreciate people saying that Dr. Rosmarin, this presentation has been helpful. People have learned more than they expected to, and so there's been a lot of great engagement with the webinar today. Any additional resources, any other things that have come up? I know you recently published a piece in Lancet as far as encouraging more awareness of the intersection between spirituality and religion. You know, what are some additional resources that you might recommend for considering this intersection of faith and mental health, especially, and then additionally where it intersects with obsessive compulsive disorder and scrupulosity?
Yeah, those are great questions. For people on, I'm going to answer the second one first. On the scrupulosity and OCD side, if people are struggling, the International OCD Foundation, the IOCDF, they have a website with a lot of resources, and it really is a great resource. They have a Find a Therapist link on their website. I happen to be a professional member of the IOCDF, and I've worked with them in the past. I think when it comes to religion, there's some very good articles that are on their website. And some good resources as well. Beyond that, I think that when it comes to faith and mental health, to be perfectly honest, we're way behind the 8 ball, and it's having some pretty bad consequences. You know, the burden of mental health in this country is growing over time. Faith leaders are often ready and able to serve, and often religion is a part of potentially a resource for individuals, but we ignore it as a field. And I think that that often happens, starts at the federal level and sort of moves down. So the fact that the Partnership Center, that you're doing such good work and you have such a large group of constituents, I guess I would just encourage everybody to stay in touch with the Partnership Center and, you know, keep up with whatever's being done, because we need more people doing it.
Well, man, I mean, I couldn't have teed out that ending any better than you just did. So I thank you so much, Dr. Rosmarin, for this presentation. Thank you for the consideration and the conversation that you've helped us facilitate today, and the increased awareness that we have now as a result. I want to thank all our participants today for the amazing questions that came in, for the dialogue that you had with us. We know your day is busy, and you've taken a lot of time out of your day to participate with us. We want you to share this knowledge more broadly. We want you to stay in touch. Over the next few months, we'll be launching new resource in a webinar series describing the basics that faith communities can know and actions that you can take to support individuals with mental illness and caregivers. So we hope you will join us for that webinar series and keep an eye out for that new resource that we'll have coming out soon. If you want to be notified of those upcoming webinars, send us a note. As Dr. Rosmarin said, stay in touch with the Partnership Center. Email us at partnerships@hhs.gov. That's partnerships with an S at hhs.gov, or go to our website, HHS, that's H as in health, H as in human, S as in service.gov/partnerships to sign up for our newsletter. Either of those will work as ways for you to stay in touch with us and to continue to connect with the work that's going on. So again, thank you for joining. Thank you, Dr. Rosmarin, for your presentation. And thank all of you for the work that you do and the ways in which you're connecting your community to address the issues and challenges for those with mental illness and their caregivers. We hope you have a very happy day, one filled with any number of different exciting and new opportunities that may be present. Thank you, everyone.